Hello. Today I'm going to be talking about Hello, my name is Dr. Judy Brangman. I'm an internal medicine resident at East Carolina University, and today I'm going to be talking about autosomal dominant polycystic kidney disease for the internist. So an outline of what we're going to cover today. First, I'm going to give you an introduction about the condition. Then we're going to talk about the pathophysiology. Then we're going to go over the diagnosis and screening of autosomal dominant polycystic kidney disease. And then we're going to discuss about the clinical features. And lastly, we'll cover the management and complications. And at the end, there will be a summary where I will summarize the highlights that I want you to remember. So first off, let's start with an introduction. Why is polycystic kidney disease of importance to a general internal medicine physician? Number one, it's actually very common. And it's actually more common than some of the other conditions that we know and treat frequently, such as sickle cell disease and cystic fibrosis. In addition, polycystic kidney disease comprises 4% of patients that have end-stage renal disease. And it's among the most common of all inherited genetic conditions. Also, as you will discover later on in the talk, patients that have polycystic kidney disease often don't develop end-stage renal disease until much later in the disease course. So they'll present much earlier, maybe age 30s, 40s, to an internal medicine clinic, or you might see them in the emergency department, and they'll come in with common general internal medicine complaints, such as abdominal pain, they might have hypertension, or they might even have hematuria. And so polycystic kidney disease needs to be on your differential when you're treating such patients, and it's a condition that's common enough that we should all know about it and also know how to treat it, because there are specific medications that are recommended to use to treat the hypertension in such patients, and there are also medications that are recommended to use to treat urinary tract infections in patients that have polycystic kidney disease. We're going to discuss all of these in detail throughout this talk. And in addition, there are some other general internal medicine medications that we use quite frequently that comprise some of the promising therapies for polycystic kidney disease. Some of these medications include Metformin, which we use commonly to treat diabetes, in addition to octreotide and Tolvaptan. And we're going to discuss some of these in detail in the therapy section. So first off, I'd like to start with a patient case. So we have a 35-year-old male with no past medical history. He comes into the clinic with abdominal pain. He also has hematuria and dysuria. His urine output is normal, and his blood pressure is elevated at 150/95. Family history is positive for autosomal dominant polycystic kidney disease. It's negative for subarachnoid hemorrhage and negative for intracranial aneurysms. And the questions that you should be able to answer by the end of this talk, because we're going to cover them, are the following. How will you screen for autosomal dominant polycystic kidney disease? What is his blood pressure goal, and how will you treat his hypertension? Should you screen for cerebral aneurysms? And if he has a urinary tract infection, what antibiotic will you prescribe? So first, let's talk a little bit about the history of this condition, which is actually quite interesting. Early descriptions of polycystic kidney disease were difficult to trace, primarily because they did not have the luxury that we have today of CT scans, ultrasounds, and MRIs. And in addition, due to the cultural practices, they were very reluctant to perform autopsies. There is mention in the literature, however, 400 BC, Hippocrates mentions 4 diseases of the kidney, although he doesn't specifically mention polycystic kidney disease, but he mentions some conditions that have similarities with polycystic kidney disease. In the 8th and 9th centuries is when they have first documented reports of autopsies being used for forensic purposes. In the 14th, 15th centuries, there are a few examples of polycystic kidney disease. But it wasn't really until the 19th century that the role of autopsy was established in the medical profession. The first known case of polycystic kidney disease was King Stefan Batory, and he's one of the most successful monarchs in the Polish history. And he died a sudden death at age 53 years in 1586. And at that time, his death really wasn't known, but prior to his death, he had 2 physicians that were taking care of him, Simon Simonius and Nicholas Bucella. And they both had different theories on how his illness should be treated. One felt that his body should be kept cool with ice and other cooling therapies, and the other physician felt that his body needed to be warmed up. And generally, there were conflicts between the 2 physicians during the course of his illness. And eventually, on December 12, 1586, when he died, these 2 physicians were felt to be responsible for his death because of the conflict that existed between them during his illness. An autopsy was not done at that time, but it wasn't really until 347 years later when the cause of death was determined to be due to polycystic kidney disease. So now we're going to move and talk about the pathophysiology of this condition, which is really important, particularly because some of the therapies are targeted towards the pathophysiologic defects. Polycystic kidney disease is an autosomal dominant condition which involves a mutation on the gene called polycystin 1, which is encoded on chromosome 16. And this comprises 85% of the cases. It tends to have a more severe disease course, and the mean age of onset of end-stage renal disease is 54 years old. There is also a mutation in polycystin 2, which is coded on chromosome 4 and comprises 15% of cases. It tends to have a less severe course, and the mean age where patients develop end-stage renal disease is age 74. There has also been described there are a small subset of there is a small subset of patients who on genetic analysis are not found to have a mutation in polycystin 1 or polycystin 2. And it has been hypothesized that maybe there is a third genetic defect called polycystin 3. However, this genetic defect has not fully been described in the literature as of yet. The genetics of this condition involves a 2-hit hypothesis. The first hit involves a germline mutation in the polycystin gene. This germline mutation alone is not sufficient to cause the disease. There has to be a second hit, which is a somatic mutation in an individual tubular cell that inactivates the normal gene from a normal parent. And both a germline mutation of polycystin 1 or 2 and a somatic mutation must be present in order for cysts to develop. So what are polycystins and what is their role in the body? Polycystin 1 and Polycystin 2 are linked transmembrane glycoproteins found on tubular epithelial cells in the kidney. They function to inhibit cell proliferation via several pathways. And one of those pathways is that they act to decrease cyclic AMP. And when you have a mutation in the polycystin gene, you get an increase in cyclic AMP. And cyclic AMP has been described to play a role in cyst formation. In addition, vasopressin, which is one of the medications that we'll talk about later in detail in the therapies, is a medication that has been shown to increase cyclic AMP. This is a flow chart showing you the mechanisms of cystic growth in this condition. So first, you have a mutation in polycystin 1 or 2, which then leads to altered mechanosensation by tubular cilia. You also get altered calcium flux. As a result, this causes altered tubular epithelial growth and differentiation, which through cyclic AMP mechanisms leads to fluid secretion, cell proliferation, abnormal extracellular matrix, which together cause cysts to form, which then eventually lead to glomerular vascular damage and interstitial inflammation and fibrosis. This is a image that shows you where polycystin functions on the cilia that's located on the renal tubular epithelial cells. And collecting ducts. Polycystin 1 is expressed primarily in the distal convoluted tubule and collecting ducts, while polycystin 2 is expressed predominantly in the distal convoluted tubule and the loop of Henle. And these cilia function to sense urinary flow as it moves throughout the nephron. The first steps that are involved in cystic formation involve hyperproliferation of the cells lining the nephron, changes in the extracellular matrix, and then through cyclic AMP mechanisms, you get fluid secreted into the lumen of the cyst. And eventually the cyst gets larger and larger. And while initially it may be a part of the nephron, as it continues to grow in size and get larger, it sort of separates itself from the nephron and functions as a distinct unit and is not able to function as it normally would. Not only does it get larger and larger, it compresses other nephrons that are nearby, which prevents them from functioning as well. Interestingly enough, the cyst, Interestingly enough, the cyst will continue to grow sort of in the background, and the renal function of the individual may be normal, until much later in the disease course, when the patient may be age 50 or 60, and then there will be a sudden decline in the renal function, despite the cysts which have been present for many, many, many years. Now we're going to discuss the diagnosis of the condition, and this table summarizes the renal cystic conditions that exist, just so that you are aware Now we are going to discuss the diagnosis of polycystic kidney disease, and this table shows you a summary of different renal cystic diseases, just so that you are aware that there are other cystic conditions that exist. You can have simple cysts, which are single, multiple cysts in normal-sized kidneys. Patients may have microscopic hematuria. Simple cysts are quite common in elderly patients older than 60 years old, and it's a benign condition. And it's important to be aware that the presence of cysts on an ultrasound does not indicate polycystic kidney disease. And in some of the next slides, we'll talk about how many cysts must be present on ultrasound before you have a diagnosis of polycystic kidney disease. You can also have medullary sponge. There's also autosomal recessive polycystic kidney disease, which presents with enlarged cystic kidneys at birth and usually results in death in infancy and childhood. There's also acquired cystic disease, and there's also familial juvenile nephronophthisis, as well as adult onset medullary cystic disease. The recommended modality to diagnose is ultrasound, which detects cysts larger than 1 centimeter, is very sensitive in adults. It's cheap and quick to perform, so it's the standard for diagnosis. You can also diagnose it with MRI or CT with contrast. This has the advantage of detecting cysts that are 3 millimeters in diameter. However, these imaging, as you know, are much more expensive, take longer to But as you know, these tests are much more expensive than an ultrasound. And there's also genetic testing, which is not recommended to routinely perform genetic testing because it's quite expensive. And then particularly in younger patients, you run the risk of the psychological effects of having this diagnosis at such a young age. Mutation detection rates with genetic testing are 50 to 70% for polycystic kidney disease 1 and 75% for polycystic kidney disease 2. The literature recommends that patients with either equivocal imaging results be tested genetically, and it's also recommended that patients that are wishing to become kidney donors also undergo genetic testing. The Ravine ultrasound criteria is a standard method used currently to diagnose this condition. And the number of cysts that must be present are different for different age groups, primarily because older patients are more likely to have benign cysts. In a patient that's younger than 30 years old with a family history of polycystic kidney disease, they must have 2 cysts total. So there can be 1 cyst in each kidney or 2 in one and none in the other. If they don't have any family history, they must have 5 cysts total. If your patient is between the ages of 30 and 59, however, they must have two cysts. If your patient is aged 30 to 59 years, however, they must have 2 cysts per kidney. While if they have a negative family history, they must have 5 cysts total. And in patients that are older than 60 years old with a positive family history, they must have 4 cysts in each kidney. If they have a negative family history, they must have 4 cysts per kidney as well. These are some images showing you what polycystic kidney disease looks like. And this is a gross section of a kidney from a patient with polycystic kidney disease, specimen B. And specimen A is a normal-sized kidney with simple cyst. And then specimen B is a kidney from a child with autosomal recessive polycystic kidney disease. And as you can see, the kidney in B from the patient with polycystic kidney disease is much larger than a normal-sized kidney. And these are just some more gross sections. Specimen D on the right there is a picture of a liver with a liver cyst, which can also be found in polycystic kidney disease as well. And then there's polycystic liver disease, which is a separate entity, just to be aware of. So how do you screen for this condition? This is very important for internal medicine physicians, because screening, oh gosh. So now we're going to cover screening of this condition, which is very important for internal medicine physicians, because a large part of what we do, particularly in clinic, involves screening. Screening for colon cancer, cervical cancer, breast cancer. There are specific guidelines on who should be screened for this condition. So in asymptomatic individuals, those are patients that don't have any symptoms. If they have a family history of this condition, you want to screen them with ultrasound. And in addition, it's important to know that it's not recommended to screen children that are less than 18 years of age. Primarily because, number one, it's low yield, and second off, again, the psychological effects of having a diagnosis at such a young age outweighs any potential benefit. And of course, you want to screen all potential kidney donors. Another important topic for internal medicine physicians is when to screen for asymptomatic cerebral aneurysms. If you have a patient that comes into the emergency department with a headache or family history of polycystic kidney disease, should you screen them? Well, definitely if they have symptoms, you'd want to work that up if they have a headache. But in a patient who is asymptomatic, who has no symptoms, but has a personal or family history of either intracranial hemorrhage or aneurysms, you want to screen them. You also want to screen individuals that have had previous aneurysm rupture, in individuals in preparation for major elective surgery, or patients that have high-risk occupations, such as a pilot, where if he had an aneurysm, rupture of that would cause disastrous consequences and inability of him to perform his job. That was not a mistake. I'm just thinking. And intervention is only indicated on aneurysms that are larger than 10 millimeters. That's because aneurysms that are smaller have a very, very low risk of rupture. There's been several studies that have shown that the risk of rupture with aneurysms that are less than 10, particularly less than 7 millimeters, is so small that it's been determined that the risk of doing surgical intervention outweighs any potential benefit because small aneurysms are unlikely to rupture. In addition, the risk of a new aneurysm after a patient has had a negative imaging study is only 3% at 10 years in a patient with a family history. So what are some of the clinical features? Patients with polycystic kidney disease can present with intracranial aneurysms, as we just discussed. And the incidence of this is not that high. Only about 6% of patients with autofamily history have intracranial aneurysms, while 16% of patients with a family history will have aneurysms. Most of these aneurysms are asymptomatic. However, the mean age at which they do rupture, if they do, is lower than the general population. So they may rupture at age 39 versus 51. But keep in mind, as we mentioned earlier, that the risk of rupture is low, particularly if they're smaller than 10 millimeters. Another important clinical feature is hypertension, which is another condition which we treat quite often, just in general, internal medicine, every day. One unique feature of this condition is that they will present with hypertension in childhood. However, at that same time, it has been shown in studies that 50% of patients aged 20 to 34 years with autosomal polycystic kidney disease have hypertension and normal renal function. So again, if you have a patient that's in this age bracket that has high blood pressure, normal creatinine, you should still be thinking polycystic kidney disease, particularly if they have hematuria or frequent urinary tract infections. It should at least be on your differential. In addition, patients can also present with mitral valve prolapse, which present in about 25% of patients with this condition. Also, about 50% of patients who are age 40 will present with left ventricular hypertrophy as well. Liver cyst is a most common clinical feature, which is present in about 80% of patients. And it has been shown that estrogens stimulate hepatic cyst-derived cell proliferation. Patients can also have cysts in the seminal vesicles, the pancreas, the arachnoid membrane. And although this has not been studied in detail, this is probably primary... No, let's not say that. Liver cysts are one of the most common clinical features which are present in 80% of patients. It has been shown that estrogens stimulate hepatic cyst-derived cell proliferation. Patients can also present with cysts that are located in the seminal vesicles, the pancreas, and the arachnoid membrane. Another common clinical feature is abdominal pain, which is present in about 60% of such patients. The abdominal pain is usually due to either hemorrhage, cyst rupture, nephrolithiasis, and generally increased kidney volume. Kidney volume can be significantly increased in these patients because as the cysts grow, they get larger and larger and compress nearby structures located in the abdomen. Nephrolithiasis is another clinical feature which is present in about 20% of patients. And it's important to keep in mind that uric acid stones are more common than calcium oxalate. Patients can also present with urinary tract infections, which tend to be more common in women. In addition, renal failure requiring dialysis develops in about 50% of patients, but not until the 4th to 6th decade of life. And this is important because, as I mentioned earlier, these patients will be managed in a general internal medicine clinic, and it's not until later in the disease course when they really develop chronic kidney disease and end-stage renal disease. And you remember back to the history slide when I mentioned about King Stephen Bathory, who died at age of 53. What most likely happened to him was that he suddenly developed renal failure, uremia, and then died as a consequence of complications from that. And in addition, it's important to know that there is no increased risk of renal cell carcinoma with patients who have, go back. In addition, it's also important to note that there is no increased risk of renal cell carcinoma. Now we're going to go to discuss the management of this condition. And we're going to discuss each of these in detail. How do you manage the hypertension, the abdominal pain, urinary tract infections, nephrolithiasis, and then we're going to discuss some of the targeted therapies that are listed here, and then we're going to talk briefly about renal transplant. So first, let's start talking about the management of hypertension. This slide shows you the renin-angiotensin-aldosterone system, which is very important in polycystic kidney disease. This system is basically an overdrive. And this slide just shows you an overview of how this system functions in a normal patient. First, you have angiotensinogen that's converted by renin to angiotensin 1, which is converted to angiotensin 2 by ACE, which leads to a variety of cellular functions. You get increased sympathetic activity, increased aldosterone secretion, increased ADH secretion, which all function to cause water and salt retention, which as a result increases the effective circulating volume. Now, patients with polycystic kidney disease in some studies have been shown to also be able to produce angiotensin 2 despite being on ACE inhibitors. And they're able to produce angiotensin 2 through a separate pathway that hasn't been fully described called the kinase pathway. And so there is a trial going on currently that's looking at using an ACE inhibitor and an angiotensin II blocker to treat these patients. This is another slide that shows the role of the renin-angiotensin-aldosterone system. And as you can see, it starts out with cysts compressing the renal vasculature, which basically causes the renal cells to detect a decreased effective arterial volume. And so as a result, increased renin is produced, you get increased angiotensin II, despite there not really being a decrease in effective arterial volume, which as an end result causes increased growth factors, increased angiogenesis, which directly causes the cyst to proliferate and expand even further. You also get endothelin production, increased sympathetic activity, which leads to an increased systemic vascular resistance. There's also increased aldosterone, which leads to increased sodium retention, and there's also increased renal fibrosis, which all lead to hypertension and renal disease, which is why it's very important to treat hypertension aggressively in such patients. Of note, patients with polycystic kidney disease who also have hypertension have been found to have larger kidneys and more likely to have left ventricular hypertrophy. There have been few studies that have shown that ACE inhibitors actually reverse left ventricular hypertrophy more than calcium channel blockers. And it's also been shown that there is a significantly greater reversal at a blood pressure target of less than 120/80 versus 135/140/85/90. However, there are several other small, unpowered studies that show no benefit in renal progression with the use of ACE inhibitors. So there's a meta-analysis that compared the progression of polycystic kidney disease patients treated with ACE inhibitors to those without. The mean follow-up of all the different studies was 2.3 years. And they found that the patients that were treated with ACE inhibitors had a mild decrease in mean urinary protein excretion. However, the study did not demonstrate that there was a decline in overall kidney function and creatinine, nor did it show that there was a decline to the progression of end-stage renal disease. However, it did show that those treated with ACE inhibitors had a decline in systolic blood pressure by about 6.3 and decrease in diastolic blood pressure of about 6.6. The relative risk of doubling creatinine or renal failure. Unadjusted was 0.73, the 95% confidence interval of 0.41 to 1.29. Basically, the findings were inconclusive. The patient sizes were small, and as you can see, the confidence intervals were pretty wide. The HOPE trial is an important trial that involves two multi-center, prospective, randomized, double-blind, placebo-controlled trials that has two arms. The first arm is comparing lisinopril and Tolvaptan, so an ACE inhibitor and an ARB, to lisinopril alone. in patients who have a GFR greater than 60. And in study B, they're looking at the same medications, but in patients who have GFR between 25 and 60. The estimated completion date is April 2013. And the reason why they're comparing ACE inhibitor and ARB to ACE inhibitor alone is because, as I mentioned earlier, it has been shown that patients with polycystic kidney disease, despite being on an ACE, are still able to produce angiotensin II through the kinase pathway. Another feature that this trial is studying is whether conservative blood pressure goals versus standard blood pressure goals improve outcomes. So standard blood pressure goals are 120 to 130 over 70 to 80. And they're comparing which of those is better. Now we're going to talk about abdominal pain, which is another common clinical feature present in about 60% of patients, as we discussed earlier. There are several ways that abdominal pain can be treated. First, you can drain the cyst by percutaneous aspiration. There's also sclerotherapy with alcohol, and rarely surgical drainage. But the mainstay is going to be pain medications to treat the abdominal pain. There's also other modalities, including laparoscopic renal denervation, which is actually quite interesting and is being studied currently for the treatment of resistant hypertension in several studies unrelated to polycystic kidney disease. There's also laparoscopic or open surgical unroofing of cysts that can be done, and you can also inject anesthetics to help relieve some of the pain. In addition, patients tend to have frequent urinary tract infections, primarily because a lot of antibiotics have poor cyst penetration. So it's important to know which antimicrobials have good cyst penetration so that you can use those antibiotics. So lipid-soluble antimicrobials such as Bactrim and fluoroquinolones have good cyst penetration. And in addition, it's important to keep in mind that if a patient continues to have fever despite being treated with antibiotics for 1 or 2 weeks, you want to go ahead and drain the infected cyst, or in the case of a patient who has end-stage renal disease and is already on dialysis, you want to go ahead and perform a nephrectomy. And in addition, the organisms that cause urinary tract infections and polycystic kidney disease are similar to those of the general population. Patients can also have nephrolithiasis. And one measure that has been thought to be beneficial has been generous water intake. Generally, the management is similar to that of the general population. In addition, some studies have mentioned that to treat the hematuria, you can recommend bed rest, avoiding sports with the high risk of abdominal trauma, such as rugby and boxing. And you also want to hydrate the patient enough to increase the urine output to about 2 to 3 liters a day. So this picture just shows the many different mechanisms that are involved in polycystic kidney disease. Some of these are being studied in different trials, but there are only a few that I want you to be aware of, because this can be a busy slide. So this is a picture of the renal tubular epithelial cell, and the area that has been outlined in the red box is a picture of the cilia. And as you can see, there's polycystin 1 and polycystin 2. And one of the targeted therapies that we are going to discuss is metformin, which, as you can see, where it functions. We're also going to talk about somatostatin, vasopressin, and mTOR inhibitors. So first, let's talk about metformin, which I'm sure all of you are familiar with. This medication, as we use it quite frequently to treat our diabetic patients. So how does metformin play a role in cyst formation? Well, it's been shown that metformin activates a molecule called AMPK. AMPK stands for adenosine monophosphate kinase. And this molecule inhibits cell membrane proteins that increase cyst growth. Some of these cell membrane proteins include cystic fibrosis transmembrane regulator and mTOR, which stands for mammalian target of rapamycin. And in one study that was able to demonstrate that canine kidney renal epithelial cells incubated with metformin cause AMPK activation. TZDs have also been studied and shown to play a role in the treatment of autosomal dominant polycystic kidney disease. These medications are used to treat diabetes, but they have been shown to inhibit fluid secretion, which, as I showed you in the pathogenesis slide, is part of the mechanism that malfunctions in cystic formation. So TZDs have been shown to inhibit fluid secretion, which as a result inhibits cyst growth. However, keep in mind that they have a limited use due to the cardiotoxicity. In addition, Sandostatin has also been studied as a potential therapy for autosomal dominant polycystic kidney disease. There was a study done or published in Journal of American Society of Nephrology in 2010. This was a placebo double-blind trial that looked at patients treated with octreotide versus placebo. And they found that there was a slow increase in liver volume and total kidney volume, in addition to an improved health perception. Not only did they measure kidney and liver volumes over time, they also gave patients in this study questionnaires to report how their quality of life was. And those patients treated with octreotide reported overall improved health perception. Some of the mechanisms of decreased cyst development include Sandostatin potentially acts on G protein coupled receptors, suppresses cystogenic growth factors, and there's also vasopressin-induced cyclic AMP generation and water permeability. Some of the side effects to keep in mind of Sandostatin include diarrhea and abdominal cramps, which are pretty common, as you can see, in 61% and 50% of patients. So it's important to keep that in mind. And this graphic shows the effect of Sandostatin on kidney volume. And in figure B, on On the left, we have patients treated with placebo. And sort of to the right, there are the individuals treated with octreotide. On the y-axis is the individual kidney volume plotted as a percentage in change in size compared to the size at the beginning of the study. So as you can see, majority of the patients in the placebo arm had an increase in kidney volume, between 10% increase up to 30% increase. While in the octreotide arm, patients tend to have less increase in the total kidney volume. Tolvaptan is another medication that is currently being studied for the management and treatment of this condition. So as you already know, arginine vasopressin stimulates cyclic AMP production, and tolvaptan is a vasopressin 2 receptor antagonist, and this functions to decrease renal epithelial cell cyclic AMP levels. And as a result, it inhibits cyst growth, cyst proliferation, as well as inhibiting chloride secretion in human autosomal dominant polycystic kidney disease cells. One of the big trials involving tolvaptan is the TEMPO trial, which is the Tolvaptan efficacy and safety in management of autosomal dominant polycystic kidney disease and its outcome. They use measurements of total kidney volume measured by MRI, in addition to measuring changes in GFR on blood work, to determine whether treatment with tolvaptan resulted in significant improvements. They treated with patients with varying doses of tolvaptan, either 45 and 15 milligrams, or 60 and 30, or 90 and 30 milligrams for 3 years. Preliminary results have shown that tolvaptan decreases total kidney volume and also slowed a decline in GFR. So one of the last medications that we're going to discuss in the treatment is mTOR inhibitors, which are used primarily in hematology oncology. Some examples of these medications include everolimus and sirolimus, and these have been shown to inhibit cell proliferation and cyst growth in animal models. However, clinical trials show that there's no significant change in total kidney volume and GFR. And it's also important to know that the side effects profile is quite significant. And lastly, there's renal transplant, which, as I mentioned earlier, tends to renal disease. And lastly, there's also renal transplant, which, as I mentioned earlier, end-stage renal disease tends to develop between the 4th and 6th decade of life. Renal transplant is the only known cure, and also the rate of cysts developing in a transplanted kidney is extremely low. In addition, patients with polycystic kidney disease have been shown to do better than other patients on dialysis, and it is thought that this is primarily because polycystic kidney disease patients are less likely to have other comorbidities. So now we're going to go back to our patient case and the questions that I had mentioned at the beginning, which I hope that you'll be able to answer. So we have a case, a 35-year-old male with no past medical history who comes into the clinic with abdominal pain. He also has hematuria and dysuria. His urine output is normal, and his blood pressure is 150/95. His family history is positive for autosomal dominant polycystic kidney disease, and it's negative for subarachnoid hemorrhage or intracranial aneurysms. So first question, how will you screen for autosomal dominant polycystic kidney disease? So in this patient, you want to screen with renal ultrasound. So as I mentioned, the renal ultrasound is the primary modality that you should be using to screen. Secondly, what is his blood pressure goal, and how will you treat his hypertension? So his blood pressure goal will be less than 130/80. Although there are trials, as I mentioned, that are looking at stricter blood pressure goals, currently the blood pressure goal is less than 130/80. It should be easy to remember because it's the same goal that we use for our diabetic patients. Also, how will you treat his hypertension? As we discussed earlier, you want to treat them with an ACE inhibitor. And keep in mind that there are trials looking into using ACE inhibitors and ARBs. Third question is, should you screen for cerebral aneurysms? So this patient does have a family history of autosomal dominant polycystic kidney disease, so you might be tempted to screen him. However, he doesn't have a family history of subarachnoid hemorrhage or aneurysms. He does not have a personal history of such. He is not in a high-risk occupation such as a pilot. So no, he should not be screened for cerebral aneurysms. And lastly, if he has a urinary tract infection, which I didn't give the UA results, but he has dysuria, so let's assume that his urinalysis was consistent with the urinary tract infection as well as his urine culture, you want to prescribe an antibiotic that has good cyst penetration. Those will be lipid-soluble antimicrobials, namely Bactrim and fluoroquinolones. So those are the 4 take-home point questions that basically summarize the highlights of this presentation that as an internal medicine physician are going to be very important for you in your practice. It's going to be very important for you to know those if you're managing patients in the internal medicine clinic, in addition to if you're working a shift in the emergency room department. And lastly, the next 3 slides list my references. And again, this concludes my presentation on autosomal dominant polycystic kidney disease. And thank you.